So I'm going to talk a bit differently. I'm going to give you both sides of repair replacement and the reason why a lot of replacements are still done in the United States and in the world all over. So I think we need to understand a couple of things. Is first of all, the anatomy which is relevant to repair and replacement. It's not very similar or dissimilar to mitral valve replacement and repair. What are the current concepts of repair as well as replacement options? And the most important thing is what are the common issues faced by a surgeon every day? Even a referring physician, concomitant versus isolated tricuspid, primary or secondary TR, first time or reoperation, which becomes very important. It's very hard for a surgeon to open a patient second or third time and then try a couple of repairs and accept at least moderate TR. Most of the surgeons probably will just replace that valve. Pacing leads is another issue which is quite important. And the more relevant thing today is if the repair fails or replacement fails, are there any less invasive options in future? So very important difference between mitral tricuspid, and I'm sure Steve and other speakers will allude to this more in detail. But the leaflets are definitely thinner, the chordae are more less specific. There are 2 or 3 papillary muscles, there are moderator bands, and more importantly, you will see that there are some chordae coming from the ventricular wall itself. The implications of all this is as the RV dilates, you can get tethering of different severity in every tricuspid patient with regurg. When you're trying to repair or replace, as you know that a lot of transcatheter repairs, patients are turned down today because of proximity of right coronary artery. Surprisingly, in surgery, we never even bother about it, and very rarely we injure it. But the right coronary artery is always near the anterior-posterior commissure, and sometimes even most of the anterior leaflet annulus. You can see that the AV node is also near, and more importantly, aortic valves near as well. Specifically, those of us who train young surgeons to either repair or replace, and specifically in repair where we do it on beating heart, there's a chance that you can damage the aortic valve quite easily if you don't pay attention. The annulus seems to flatten out. As we all know that as the RV dilates, this flattens out. Most of the repairs, in my mind at least today, I'm going to show you in the subsequent slides that the repair rings which have been used in the past were uniplanar, that means flat, and now there's a lot of emphasis on using multiplanar rings which simulate the tricuspid annulus. However, in my mind, if you use a multiplanar ring but the RV is still dilated, probably it's not a good idea because you're not remodeling the RV when you implant the ring. And that's why sometimes we face a problem that undersized ring, a properly placed ring, the tethering still remains and you get at least moderate TR. And in those patients, I remove the ring and try and use a uniplanar ring, and at times I get better result. And Steve probably can allude to that later. We know that the tricuspid annulus is definitely not uniplanar. And this again becomes relevant when I show you pictures of the rings. The septal leaflet, the midpoint of the septal leaflet is the lowest, while the anterior and septal commissure is probably the highest. So what are the concepts of repair? Now, many times K repair and the De Vega repair is given a bad name, but I think we should remember that all these repairs came in rheumatic heart patients. And in rheumatic heart disease, most of the pulmonary hypertension is reactive pulmonary hypertension, and that is why these repairs were done pretty successfully. However, now we are extrapolating these results in degenerative population, and that's why these results don't hold water when we look at 5-year results. Other thing very important is that the tools to assess tricuspid regurgitation are primitive. Even today, majority of the tricuspid regurg patients go to OR, and I don't have Becky Han or Omar or somebody like this to tell me, oh, the tethering is this much and TAPC is this much, so you should not do repair but do replacement. And that's the truth. A lot of us assess the tricuspid valve poorly to start with, and I think that reflects on poor results, whether it's repair, and then most of these patients get replacement because of that factor. Mike has already shown you these diagrams. This is just to highlight the fact that the concepts of rings, which are the bottom 2 pictures, have changed quite a lot. And just to again show you that there are many types of rings used. There was a trend of using flexible rings. This again mainly came from rheumatic heart disease. Now majority of the rings are semi-rigid or rigid. Most of the rings are incomplete because you don't want to damage that AV node area. But the main problem is the rings can be incomplete in many ways, and I'm going to show you why. What I mean by that is you can see that the circumference covered of the tricuspid valve for an incomplete ring varies from one model to another. And I was just walking today morning, and I got a text from one of my close friends in Piedmont, Vivek, that there's a ring which is here, the triad ring, which essentially covers only anterior and posterior annulus. Now I've got a patient with a 32 size triad ring with severe TR now. Can we do a sapien in this ring? And the answer is no, you can't, because 1/3 of the annulus is not covered by this ring. So I think, again, we need to understand which type of designs we need in future properly. This topic is more spoken than actually practiced, is leaflet augmentation. When you have a lot of tethering, ironically, most of the tethering is septal leaflet, but if you get anterior leaflet tethering, etc., sometimes leaflet augmentation of either anterior or septal leaflet helps a lot. I must say that I personally have done this only once or twice in last 5 years, so the frequency of this operation, I think, is really, really low. Majority of the rings, the practice has changed now, and most of us now use rigid rings or semi-rigid rings. And this has been shown very well that undersized or not undersized rigid ring or semi-rigid ring gives you more robust results than flexible rings or custom-made rings or de Vega annuloplasty. And I think not only we're going to see more repairs done in the United States every year, but we are also going to see repairs done with the right tools on the table to see less regurgitation. I think this is not uncommon, is the recurrence. We see, I operated a patient with minimal TR on table. 3 months later, this patient presents with moderate TR, and then you wonder why the repair was proper, etc. So we probably don't understand the fluid dynamics in the patient, the volume status of the patient, and the implications when the patient follows up. I would say that in majority of the papers, contemporary results, the results have been relatively poor. However, the current results from especially large volume centers are very encouraging in terms of ring repair. Mike and again shown this, but to highlight that you should do a repair, but with a consistent technique. If you're inconsistent technique, your results are inconsistent. Secondly, most of us spend very minimal time on table to assess the tricuspid valve. If any one of us does a mitral valve, we'll spend probably good amount of time to assess what's wrong and then repair the valve. Generally speaking, in tricuspid, that time spent is much less. We still don't understand the effect of RV volume, RV size, leaflet tethering very well. Replacement, very quickly. The advantages of replacement is it's easier. Most of the valve sizes implanted are size 33 or 31. So you can probably do a future valve in valve if needed. You can do this very easily if there are pacing leads. Again, the main thing is when it's a reoperation, the surgeon tends to lean towards replacement if the repair results are not going to be very good in his hands. The problem is the pacing rates are higher, and you can imagine that even if you use epicardial leads, which you have to plan for before, many times these patients don't have a conduction block, come after 3 months, and then you have to put a pacing lead across a new bioprosthetic valve. So that becomes a main problem with this particular technique. There is still use of mechanical valve in tricuspid. The biggest problem with mechanical valve is anticoagulation management. The biggest problem with tissue valve on tricuspid is its durability. By design and by physiology, although it's low pressure, the tricuspid valves tend to last lower, bioprosthetic I mean, than the mechanical valves, and that's a matter of fact. The other thing which is important is if you have a RV dysfunction, should you actually leave some TR behind? And that's like the pop-up effect which we talk on the left side. There are 1 or 2 papers which have shown that the RV dysfunction is more sensitive 2 or 3-fold than the LV dysfunction if you stop the leak completely. And maybe this is why, repair with a bit of regurg may be better than a replacement with no regurg in some of these patients. This is Nishimura's article which was presented at ACC from 2004 to 13. These are isolated TR patients only, and you can see that there is still a fair amount of replacement being done in this country itself. Again, this is the cross-section of patients from 2004 to 13, and slowly, I think, as we can see, the trend is more towards repair. Very quickly, certain issues. Pacing leads is a big problem for transcatheter or non-transcatheter repair replacement. This is one of the indications where majority of the surgeons tend to replace the valve. However, we have got good data from Mayo Clinic now. One of the criteria here was that they would attempt a repair but accept mild or moderate TR on table if they repaired the valve. So based on that, they have classified, why this happens. We all know either the lead, tethers the leaflet or leads to a fusion or perforation. The worst is when the lead actually goes through multiple cords and then sits on the ventricle. You have no option but to remove the lead. Mike again showed a very nice video. You have to remove the lead and then put epicardial leads in those patients. And then you can use a variety of techniques such as just cut off the leaflets, resuture it, or patch it with a pericardial patch or core matrix patch, and then try and repair it and support it with annuloplasty. But again, I think you can see that even in Mayo Clinic, that replacement in these patients, the percentage is 46%, so fairly high. A lot of these patients, again, have mortality within, I would say, 4 to 8%, which is the national figure at present. Even in experience center, the same mortality is replicated. So in my view, I think the replacement rate is still high in this country. I don't think it is 10 or 8%. I think the replacement for tricuspid happens more frequently than that. It happens less common if it is an isolated TR. It happens more common if it's reoperation, I would say, and in presence of pacemaker leads. Inadequate repair, especially even if you put a ring or you want to augment a leaflet and you still get a lot of TR, I think most patients will replace the valve. Very important to also decide on the table is what's the RV function. And again, another important thing is what is the life expectancy of that particular patient. If the life expectancy is less, maybe just a replacement for that patient is good enough, in my opinion. Very quickly, in future, we are going to need this option. As you can see that all the tricuspid rings are rigid and they're incomplete. They pose a very unique challenge when you do a valve in a ring. If you can get the sapien right in the center, it can inflate very nicely, just to show you that there will be a gap. But there are 1 or 2 cases, unfortunately, reported where the tricuspid valve, sapien valve ends up in the gap and then gets caught as you get inflated and leads to actually bigger disasters. So those of you are undertaking this procedure, just keep in mind that these things can happen if you are not aware of this procedure properly. Very important, this paper again shows that you can see the sapien valve is oval. So this is not going to last very long. And these rings are so rigid that the pre-implant and post-implant diameters are the same. So again, I think we need to redesign rings in different ways, which the project is already undergoing. So in conclusion, repair is definitely favored by most surgeons. Replacement, in my view, is influenced more by whether it's a first time or concomitant surgery versus isolated and reoperation. Standardization is critical. All of us should standardize our techniques to get better results. More role of liquid augmentation. I think if we use the echo more, we'll probably pre-select these patients properly, assess them properly, and then, depending upon pulmonary hypertension, RV dysfunction, etc., we'll choose the right repair to give us more robust results. And if you have to replace, tissue valve is the one which is favored. Thank you.